Can everybody hear me? Welcome to the second, well, actually it's the third LMPCA town hall. We met in January for the first time, and we met a subgroup of people in February, actually exactly 1 month ago, and now we're having the larger group join us once again. We have a lot of information to give to you tonight. We have a number of questions that were already sent in beforehand that we're going to sort of get through, hopefully, mostly through the presentations, and then we hope to break out into some smaller groups and talk a little bit about a few of the things that we are going to be bringing up, and then at the very end we're going to come back again and we'll have questions and answers before we say good night. So thank you for taking some time tonight to be with us. First speaker tonight is going to be Gord Schachter. Gord is probably well known to many of you. He took quite a big role in the LIN previously when the LIN existed, and Gord has continued to be a huge primary care leader in the OMA and in the LMPCA. So I'm going to hand things over to Gord to tell us a little bit about the LMPCA.
Thanks, Phil, and thanks for everyone coming out in their evenings. We really appreciate your time. So just want to talk a little bit about the Primary Care Alliance. Most of you have heard of it, which is why the reasons why you're here today. But just want to give a little bit of background of where we've come from, where we're going. So the reality is one of the reasons why we created a Primary Care Alliance is because we felt that primary care needed to be organized. There needed to be some organization to the sector to act as sort of a unified group, a single voice. And then it became even more of a burning need when Ontario Health Teams, the concept was introduced almost about 2 years ago now. It's basically the end of the fiscal year 2 years ago. And so we're really at that point. And so what's happened then over the last year and a half to 2 years is we developed a voluntary group of interim leaders within the Primary Care Alliance, which was allowing us to eventually, the goal with the eventual need to create a formal governance, which is kind of where we're leading to today. But what happened in the middle of all this is COVID hit last year, and it kind of slowed us down or railroaded a little bit of the initial work because there was such an urgency to deal with COVID. But those urgencies of COVID showed what the Primary Care Alliance needed to be doing and what it could do. For example, the coordination and organization of PPE is just a great example of how that happened. Dealing with flu shots, for example, in the COVID pandemic, what are the strategies? We needed to discuss that. And so this is the type of things that were really important for us as primary care providers to be able to group together, converse, and come to consensus on best ways of doing things for ourselves as individuals, but also as a sector. So one of the things then we did in the late summer last year is a governance committee was created to develop a vision and mission, for the Primary Care Alliance. I just get you to go to the next slide, Janet. And so what we did is we created a vision and mission for the Primary Care Alliance. And so I will just quickly read the vision: to be an inclusive network of primary care providers leading with a unified voice to improve the health of our community. And the mission was to create a strong, united primary care network to lead system change utilizing the quintuple aim principles or values, drive health equity and continuous quality improvement for the best possible experience and health outcomes, advance patient-centered equitable care in partnership with those we serve, and to improve integration of primary care health services with public health and other social and healthcare partners. So what we did is we created the why, we created sort of the goals, what we wanted to do, and the next thing we need to do is create the how. So that goes to our next slide. So this is the concept of the how we're going to create the Primary Care Alliance and the vision of how it will work. So the idea of the concept of Primary Care Alliance, which we've been striving for, is to be an inclusive group of all primary care providers, regardless of what type of practice they're in as a family physician, but also the type of work that they do or the type of profession you would sort of self-identify as. So for example, are you a nurse practitioner working in primary care? Are you a pharmacist? Are you a social worker, etc.? So we wanted to be inclusive of anybody who provides primary care. So that was the first thing. Automatically, anyone who considers themselves to be a primary care provider in some manner would be included in the membership. Then from that group, we wanted to create a primary care council or an executive group or a leadership group, and maybe we'll redefine that once that group is formalized, what they want to call themselves. The idea is that this group would be elected by the Primary Care Alliance membership. And so this is kind of where we're on the cusp of today is where that will be, which I'll just talk about shortly. Once this executive group is chosen, then from that group, the group can decide who will be the representatives at the Western Ontario Health Team representing primary care, who will be the representatives for at something called the Ontario Primary Care Council, or any other things that may come up that need primary care representation. So from this, we've created a terms of reference for our group, and looking at concepts of how this group will interact with the Western Ontario Health Team. And then from the executive group, the idea would be there would be some representation based on the distribution of providers. So particularly from a physician point of view, we looked at the percentage in the whole Middlesex area that are fee-for-service in a CCM model, in a FO or FIN model, and whether they're in a FO or FIN model affiliated with a family health team, or whether they work in a community health center, or whether you're a focused practice family physician. So the different types. We also recognize that there's some academic physicians we want to include. Then we also have some of the other groups, including nurse practitioners, et cetera. So that's sort of kind of where we're looking at from a representation point of view. So we'll just go to our next slide then. So we're really at what our next steps are. So over the last few months, we've had some various outreach meetings where some of the members of the interim executive may have been able to come out to you and do some presentations on the development of the governance and where we're at, and hopefully you've had a chance to hear it. However, you are hearing it today from a little bit more of a condensed version. The next step is, as of yesterday, we've started advertising through multiple means, including social media and email, an expression for interest for anyone who wants to be involved in the Executive Council leadership. So the idea is, if you feel that you want to be involved, we want you to go to the links that have been provided, and we'll make sure they're provided for you. If you need them, just you can email any one of us if you know us, or email Janet if you have her email address if you don't have that. The idea is to fill out your expression of interest. There's some questions we want people to answer to try and get a bit of an idea of who you are. And then as of April 6th to 13th, we're going to have a 7-day type of election process where if we have positions that need voting, that we may have some that are acclaimed. For example, if we only have one individual and there's one spot in an area, then an individual will most likely be acclaimed, but we need to have some voting if there are multiple individuals. So we'll have that election during the week of April 6th. And then as at the middle of April, we'll have a transition into the leadership role where the executive will be formally announced. So that's kind of where we're going. We want this to be inclusive. We want our group to be influential. We want our group to be grassroots. We want our group to influence change. We want our group to lead system change. And I think that's really our underlying goal, is that we all have the ability to have our part, whether it just be coming to these sessions, whether they become monthly or quarterly, or actually having an active role in the executive. We want you to have a communication channel with the executive to be two-way so that you're listened to and action can happen from your concerns. Thanks very much. Here's the sign up for the newsletter. Sorry, I was just going to mention that. So, but anyways, we'll be sharing these slides at another later time.
Thank you very much, Gord. As always, very well spoken and succinct, so thank you for that. And I do encourage everybody, as Gord has just done, to please continue to be very much involved with the LMPCA. We need all of your voices as much as we can. We have meetings on every second Tuesday morning that you can also join, so please, please, please be part of the LMPCA. We're now going to ask Alex Summers, the Associate Medical Officer of Health, to give us a bit of an update on the vaccine situation and all sorts of tidbits on what we need to know to get vaccine into people's arms.
Thanks, Phil, and thanks, Gord, for that lovely outline of the LMPCA, and I look forward to the day where the LMPCA gets to talk about non-COVID things, as do we all. I'm just going to share my screen. I got a few slides that I'll go through, as long as the slide shares all right. But again, thanks for joining me. I'm Alex Summers. I'm the Associate MOH at the Middlesex-London Health Unit. It's been a real pleasure to get to work with the LMPCA over the last little while, and with greater frequency moving forward as we look towards a vaccine rollout of more and more vaccine for COVID-19. So I'm going to try and hit a few highlights of common questions that have been asked and start to talk a little bit more about what the nuts and bolts of the vaccine distribution to primary care and how you will get it into the arms of your patients is going to roll out. The details are going to be a bit vague tonight because the details are still getting ironed out and sorted out as we get a better understanding of how this is going to roll out and what the expectations from the province are. But rest assured, we are certainly rowing in this direction, and we're really grateful for your interest in all of this. So I wanted to highlight kind of where we're at to date. As of today, we're well over 65,000, pushing 70,000 vaccines that have been administered in the Middlesex and London area. That's a total of both first and second doses, but as you're aware, the second dose for many has now been pushed out to that 4-month interval, which is allowing for us to administer first dose to significantly more people. We've also had now Moderna arrive in the region, which allows for us to start to think really acutely and imminently about what forward deployment and distribution through primary care will look like in the very, very near future. So where are we? Well, phase 1, as we have called it, is nearly completed. And in phase 1, the groups that were eligible to receive vaccine were healthcare workers, residents, staff, and essential caregivers associated with long-term care, retirement homes, and other congregate settings for seniors, those over the age of 80, and another group that's escaping me, but we'll get to it in a second. Phase 2 is where we start to see vaccine supply improve greatly, and where we start to see clear avenues and clear need for primary care to assist in the distribution, not just through mass vaccination clinics, which I'll speak about in a moment, but through other venues as well. We've already started on those over the age of 75. That eligibility was expanded on Monday. And as of Monday at noon, all the appointments and all the vaccine that we had in the region was essentially booked up for the next week for that cohort. And we anticipate additional appointments coming on board every single day to try and round out the eligibility criteria for this group. So things are moving forward, which is good. The province yesterday released its final version of the phase 2 prioritization guidance document. It's available on their website, and potentially we'll try and distribute that through the MLHU Healthcare Provider Alert. But in it, it really kindly outlines all the different stages of phase 2. As in all things with this pandemic, there are phases and there are stages, and they're interwoven and they cross over each other. So I try to keep up, but man, oh man, does it go quick. But here's where we are right now for phase 2. There are a few different segments of people that are going to be the focus of this effort. Older adults remains the primary focus for these vaccination efforts because age continues to be the most predictive risk factor for a poor outcome when it comes to COVID-19. You can see that we've already started with those over age 75, and we're going to continue to walk through in 5-year bands the cohorts until we hit those over age 60. This timeline actually suggests that we're going to hit over age 60 sometime in May. I actually think that that's going to probably move forward. The other stream is individuals with health conditions. There are 3 categories of health conditions that have been provided and articulated by the provincial government. There's highest risk health conditions, high risk health conditions, and at-risk health conditions. And I'll highlight what those are here in a moment. But you're going to start to see your patients in these groups. And it's particularly as we get to at-risk health conditions where primary care will play a critical role in either helping to guide your patients to the mass vaccination clinics or hopefully providing vaccine in your offices if we're able to get supply in our region that allows for us to do it in that way. The other groups that are going to be eligible are high-risk congregate settings that aren't for seniors. So the remainder, thinking shelters, group homes, Elgin Middlesex Detention Center, We're already planning to go out to London-Middlesex in about 2 weeks to do inmates, and their staff will be eligible at the MassVax clinic shortly. So we've had significant outbreaks in that setting and trying to make sure that we're present there. The other groups that are going to be eligible through phase 2 are COVID-19 hotspot communities. Middlesex-London is not one, so we don't have to worry about that stream. And the last group is essential workers who cannot work from home. And the reason I want to highlight that group is that they're down in June, and that's when we're talking about educators and other frontline workers and things like that. So if you're starting to get questions about patients, like when am I eligible, that group is certainly going to be eligible, but they're later stages of phase 2. And that's a really important kind of expectation setting thing for us, because we realize lots of people see themselves included in phase 2, and indeed they are, but there are different stages within phase 2. So I wanted to talk a little bit about the primary priority for phase 2. It is really going to be focused on adults aged 60 to 79, starting with those 75 to 79 and decreasing in 5-year increments. So I've already commented on that. I really think we're going to move quite aggressively through that in Ontario and likely get down to that age over 60 near the end of April, beginning of May. Individuals with certain health conditions, starting with highest risk and high risk health conditions, and I'll talk about exactly what those are in a moment. High risk congregate settings, and then those hotspot communities. And you'll note that the primary priority does not include those other frontline workers. They're indicated and classified in the secondary priority group, as well as with remaining individuals with at-risk health conditions. Again, we'll look at those in just a moment. So when we're talking about highest risk health conditions, as I said off the front, we've got 3 major strata of health conditions that are being considered here. Highest risk health conditions refer to a very small segment in the big scheme of things of patients. Organ transplant recipients, hematopoietic stem cell transplant recipients, neurologic diseases in which respiratory function may be compromised, such as MS, hematological malignancy diagnosed within the last year, and kidney disease with an eGFR of less than 30. So this cohort are the medical conditions that have a greater risk of poor outcome relative to those age cohorts. So quite frankly, even with dialysis, the increased risk of dialysis relative to like a 50 to 55-year-old who's otherwise healthy is about 2 to 3 times, whereas somebody who's 70 is like 6, 7 times higher. So this is why the age push remains the predominant push, because we're trying to kind of move through people's relative risk increase with the condition or age that they are at. This group, the MLHU and most health units strategy in reaching this group is recognizing that we actually can find the specific clinics for whom these people are associated with and disseminate booking information directly to patients through those clinics. So we're meeting tomorrow, for example, with St. Joe's, London Health Sciences Center, and all the directors of the specialist clinics that deal with these patients in order to disseminate booking information directly to them. One of the messages will be to primary care. That's the strategy with this group. If, however, you have a patient that isn't being assessed by one of those clinics, you're aware of them, they clearly fall within this category, just send us an email so that we can get them sorted out. The hope is that that's going to be a small number. We're also going to be working with the hospitals who already have access to some of the COVID vaccine and our mobile teams to disseminate vaccine in clinic if necessary to some of these patients. Most of them will be ambulatory and hopefully therefore will be able to be seen in the MassVax clinic. So that's the highest risk health conditions. There's also essential caregivers. One essential caregiver per patient is also eligible as part of this, and they again will receive the booking information directly through those specialty clinics. The next strata of health condition is called high-risk health conditions. You've probably heard me, if you've listened on the MLHU healthcare provider briefings a couple times a week, me kind of laugh a little bit at the way that they've named all the different risks. So with healthcare workers, they called us highest, very high, high, and moderate, just to make sure we all felt included, which was very nice of them. And they've taken a relatively similar approach when it comes to health conditions, but I think it does, certainly recognize the fact that the risk remains. The high-risk health conditions are BMI greater than 40, other treatments causing immunosuppression, chemotherapy, immunoweakening medications, as well as intellectual or developmental disabilities. So This group doesn't have clearly defined clinics that we as MLHU can go out and track with. We are absolutely going to be relying on primary care to assist us in identifying these patients to make sure that we get them access. The pathways for patients to get access to vaccination, if they fall in this category, is going to be either through the mass vaccination clinics and us sharing booking information with you to help book your patients, or again, depending on vaccine supply and our process and how quickly we get to this group, administration and distribution of vaccine to you as primary care. So again, this is probably the first cohort where I imagine we may see primary care in your office delivering vaccine to these people. However, we may still be relying on mass vaccine clinics. So this is going to be one that's, let's see where we get to by the time this group is eligible. The last strata of health condition is called at-risk health conditions, and it's long. So when you are looking at this list, I'm not even going to read it all out, but you're going to see many patients within your practices identified within the health conditions that are listed here. Everything from dementia to hypertension with end organ damage to pregnancy. This group is definitely the group where we are going to be relying on primary care to either help us deliver the vaccine in your clinics or help us direct these patients to the mass vaccination clinic and help them book in. There are other jurisdictions, both in Ontario as well as across the world, when they look at kind of queuing these people into the lineup to get vaccine. Many jurisdictions rely on self-attestation, which means that MLHU, we would essentially publish these conditions and say, if you define yourself here, you can now go book at the mass vaccination clinic. Obviously, the risk there is queue jumping, et cetera. But at some point in time, we just have to, again, trust that people are going to align themselves, and we're going to try and get people through as quickly as possible. That's one strategy. The other strategy, again, is to really try and coordinate it through you as primary care. And I think we'll be looking to try and do that as much as possible. So as I mentioned, some of the details on this stuff are going to continue to evolve over the next little while, but I want to give you a sense of the timelines and the landscape here. I would say, just back to these strata, the highest risk health conditions, I think these folks are going to be eligible within a week or two, likely. High risk health conditions, probably within the next 3 to 4 weeks, somewhere around those lines. And then at-risk health conditions, we're talking about probably into May, once we really get through many of those age strata that I've articulated before. So with that, I just want to talk about, again, where we're at in the region and talk a little bit more specifically about the plans for involvement and engagement with primary care. And again, thanks to the LMPCA intern leadership for their partnership through this. So the mass vaccination clinics continue to mobilize. North London Optimist Community Centre opened up this previous week. This is Shirley Banks on the right-hand side, who received her vaccine, the first recipient at NLOC, and that's one of our vaccination nurses staff. The North London Optimist Centre, for those who've never been there, it is massive. And our capacity at NLOC, if you can see the pictures here, is going to be huge, similar to what we're going to be able to put through at Agriplex. It opened its doors on Thursday. Earl Nichols is also online to open up, but we have to pretty much double our vaccine supply in order to justify opening up Earl Nichols. I'll show you a little bit about our current utilization of our mass vax clinic capacity, but we still have got a ways to go, which is good news. We've got room to grow. I also would note that the pharmacies are rolling out AstraZeneca across the province. It has not yet arrived in Middlesex-London. The coordination with the pharmacies is happening directly from the province to the pharmacies, similar to how the influenza vaccine gets rolled out. So I don't have a huge line of sight on exactly when that's happening here. They did ask for some guidance around regions in the city that would benefit from having pharmacies available to them. And so we picked some of the regions where we know transportation to mass vax clinics, higher COVID rates, that type of thing. We indicated that if there was going to be vaccine heading to pharmacy, we would like it to go there, but we don't have a whole lot more detail at this point. So I just wanted to describe the mass vaccination capacity, just so you're aware. The Agriplex has a capacity of about 2,000 doses a day. Its current use is 13,000 doses a day. Mount Bridges has a capacity of 580. Current use is between 300 to 350. And NLOC has a capacity of 2,000, and it's sitting at about 400. So you can see how much room we have to grow with regards to mass vaccination clinic capacity. So we've got a lot of room here, which is good news. So what I want to highlight, and what we will certainly have, I'm sure, some questions on as the evening progresses, is around the expanding role of primary care. I want to first highlight that thank you to all of you who have signed up to be immunizers at the mass vaccination clinic. One of the reasons you probably haven't been called up for a shift yet is because, as you can see, we still got lots of room to grow. But thank you very much for signing your contracts, getting it in, getting your COVAX training underway. I'm realizing that this is a bit of a bumpy journey at times, but thank you very much. If you haven't been yet tagged in to do a shift, please hold tight. There will be opportunities as we continue to have capacity increase and vaccination appointments increase at the Mass Vax clinic. So again, thank you very much for those that have signed up. Please bear with us as we await more product so that we can open up more vaccination lines at these mass vaccination clinics. The capacity, again, just to highlight that we have between Earl Nichols, Agriplex, and Mount Bridges alone is 4,500 doses a day. We add on Earl Nichols, that bumps us up to somewhere between 6,500 and 7,000 doses a day. So lots of capacity to get through massive swaths of our population when that vaccine supply is available. However, in addition to mass vaccination clinics, we know, and certainly have heard through the LMPCA leadership and others, as well as our own experience, of course, that there are those who are currently eligible who aren't going to be going to the mass vaccination clinics to receive a vaccine. And so we need to look at novel ways in which to administer those doses. One of the projects that the LMPCA and MLHU are working away at is a program for delivery to homebound eligible recipients. So these are essentially house calls. Looking at a way in which we can do that. This will obviously be a small number of patients. This is not about efficiency when we're talking about house calls, as you guys are well aware. This is about reaching the folks who are the hardest to reach. It's only possible with really Moderna or Pfizer, Moderna or AstraZeneca. This is not a Pfizer candidate here, but we are starting to see more and more, or potentially more and more Moderna become available. So we're working to look at what that pilot project will look like. And trying to think of ways in which we can move Moderna. So we'll likely look at a bit of a pilot process and then look at rolling it out a little bit more. So that's underway. And thanks so much again to the LMPCA for their leadership and partnership on this. The big one, of course, is what about distribution to everybody's clinic? This process is very much in the works. We hope to have our processes articulated by the end of this week. And we'll certainly work through with the LMPCA to make sure it works, potentially look at a pilot project. This is a little bit different than the flu vaccine distribution process due to the software required to document the delivery of the vaccine. So it's called COVAX. You've probably heard rumblings about it. We need every family physician and every primary care person who's going to deliver COVAX to be registered, trained on COVAX, and we need to have a way to make sure we're tracking all this inventory. So it has a complexity that influenza vaccine distribution does not. When you guys order influenza vaccine, you order what you need. If we have it, we give it to you. And obviously, sometimes we don't have it, but ideally we do. And then you take it and you go and do your thing. A little bit different here. So the process that we are trying to get in place by the end of the week so that we can start to roll it out is one in which we would have essentially a contract with you with regards to COVAX, some training modules in place. We're able to support you in some software and data and IT support, and then have a ordering process by which you can get vaccine and run your own clinics in your own facilities. So this is very much on the horizon. Our hope is to have the process really fine-tuned over the next week so that we can start to pilot it, so that by the time mid-April rolls around, when we are really looking at getting vaccine into some of those high-risk health conditions, let alone when we're looking at getting it into at-risk health conditions, we are really able to utilize primary care as a key delivery vessel for this vaccine. So, as I mentioned, details, a little fuzzy. Process and vision, though, certainly beginning to come to play. I just wanted to highlight quickly, and I do not want to run over on time because we've got lots of breakout rooms and questions, but there were some questions that the LMPCA leadership flagged for me that there was some concern and questions about. So I just want to highlight very quickly around vaccine specifics. AstraZeneca for 65-year-olds. You may be receiving questions from your patients about, I'm 71 years old. Do I go and get AstraZeneca if a pharmacy is open? What do I do? What's the best plan? Long story short is that the original NACI review and NACI is the National Advisory Committee on Immunization. It's the federal body that provides all of our guidance around how to utilize vaccine. Arm's length, not corporate, the whole deal. The initial AstraZeneca phase 3 clinical trials had very small numbers of participants over 65 years of age. Therefore, the NACI looked at that and decided we're just going to look at those under 65. That was the initial NACI recommendation. However, as you're probably aware, it was updated recently to indicate that AstraZeneca could be used in anybody over the age of 18, which therefore meant those over the age of 65. The reason is that there is increasing real-world evidence from the United Kingdom, as an example, that has been administering AstraZeneca for quite a while now to those 65 years of age and older with great success, demonstrating high safety and effectiveness of the vaccine in older adults, particularly and most importantly against severe COVID-19 disease and hospitalization. So that's good news. Of course, there's been lots of other questions about AstraZeneca, specifically around thromboembolism. I just want to tell you the story that's gone along with this. I'm sure you've been following it. And even today, AstraZeneca is in the news for the wrong thing. However, it appears as though the vaccine itself, there's some clarity there. Health Canada was informed by the European Medicines Agency on March 8th that one of the countries, Austria, had stopped using a batch of AstraZeneca after one person was diagnosed with multiple thrombosis and died 10 days after vaccination. A second individual was hospitalized with a PE after being vaccinated. That person was recovering. So as a result, Health Canada was also notified on March 11th that an additional fatal report had been received in Europe. Several countries, including Denmark, temporarily paused the use of specific batches or the AstraZeneca vaccination as a precautionary measure, pending the outcome of the EMA's investigation. EMA went and investigated. We went from March 8th to March 11th. In the meantime, the United Kingdom issued a response on March 11th, indicated that they'd already delivered 11 million doses of AstraZeneca in the United Kingdom, and they had not seen more reports of blood clots in the vaccinated population than would have been expected in an unvaccinated equivalent population. The EMA concluded its preliminary review on March 18th, 10 days later, and did not observe an increased risk of thromboembolism and no evidence of problems with particular batches, and concluded that the benefits far outweigh the risk. Health Canada again today reiterated its confidence in the safety of this vaccine and continues to be recommended for those over the ages of 18, including those over age 65. And again, for those over 65, again, it was about the efficacy in that population, but the real world experience through the UK and others is that when it's effective, and particularly when we think of severe outcomes and hospitalizations, AstraZeneca is a good option. So our driving message will continue to be take the first vaccine that you can, take the first vaccine that you can. And that will continue to be a really, really critical message for us. My father is 60 years old and he got his AstraZeneca vaccine today in Toronto. So on my recommendation and strong encouragement, I might add. With that, I'm happy to, I know questions are coming at a later time or at any point in time, but that's kind of where things stand at the health unit at this point, and many irons in the fire to say the least. So thanks again for having me at your town hall. I know there are so many awesome primary care things to talk about, and the privilege is mine to take up some airtime. So thanks so much. I'll pass it back to you.
All right, thank you very much, Alex. That was absolutely fascinating, and thank you for the up-to-date information. We're now going to have a presentation by two of our vaccine task force members, Dr. Mario Ilya and Dr. Julie Clarke. Both of them are family physicians that you may very well know. Mario has a little bit more TV, YouTube, etc. presence, but our Julie Clarke is equally wonderful. So I'm going to turn it over to the two of you to discuss a little bit about what the LMPCA has been working on.
Thanks, Phil. You're making me sound Hollywood. It's
Well, you are.
Local television,
Mario.
Southwestern Ontario television. So keep it relative. Thanks for the intro. So Dr. Summers touched on a few of the things that I'm going to touch on in his presentation. So mine should be pretty brief. The LMPCA, a few of us have been having really good conversations with Dr. Summers and his team over the past number of weeks, expressing a lot of what we know a lot of you in primary care are sensing and potential gaps you guys have identified in terms of immunizations. And the big one that we've been bringing to their attention, they've been quite receptive to this, is our homebound patients who have not been able to get to the mass vax clinics who are otherwise eligible for vaccine. And the barrier up till now to getting them vaccinated has largely been having Moderna, having AstraZeneca available, because just the nature of Pfizer, and again, once that vial is punctured, transporting multiple doses to individual homes was identified as being challenging. And once Moderna became a player in the city, then our conversations have kind of ramped up from there. And we're having some good conversations about, how are we going to vaccinate these homebound patients? So the way I would break it down to you is there's kind of two big groups. So there's the group of homebound patients who have a connection right now to home and community care. So they're receiving some kind of LIN services over a chronic period of time. And then there's the group of patients who have difficulty accessing the mass vax clinics who are not connected to home community care. So those are ones who we as their primary care providers and physicians have probably the most intimate knowledge of who these people are. So they're people who could have identified to us specifically over the last few months that, doc, there's no way I'm going to one of these mass vax clinics. My hip's killing me. I'm not leaving the couch. The only way I'm getting a vaccine is if someone comes to my home. So we know who those patients are. So the group that's associated with home and community care, what's been happening up till now is their care coordinators have been reaching out to all of those patients to, number one, if they can get to a mass vax clinic, to get them to go there, to get them signed up for an appointment and sending them there. If they're a patient connected to home and community care who cannot get to the mass vax clinic, they're being entered as a data point in CRIS, I believe, so that when we have between public health and home and community care, they have the ability to send nurses in to vaccinate these patients. They'll know who those patients are. Okay, and this is in flux right now. I know Dr. Summers and I spoke earlier in the week about how many nurses would be dedicated to that, and that's in flux right now. But that will be happening, and we'll see kind of how quickly they can get through those patients. But what we can work on, and what we're working on, is the patients who are not connected through home and community care. So the process for it will, again, we're working on it, but what we're going to need from family docs, and we're going to put out a specific ask with exactly what we need from you and what the process will look like. But what we're going to need is essentially a list of patients in that group, homebound, can't get out, not getting out, willing to be vaccinated, but not connected through home and community care. We'll explicitly state exactly what demographic information we need. We'll be asking whether you, as their physicians, will be able to get, are you able to go and do house calls on these patients to do vaccines? Because it's not a huge number. These aren't the ones who aren't attached through home care, but homebound. It's not a huge number if you look at your own lists. So are you willing to do house calls? We hope you are. And if not, then again, we'll have to figure out some kind of mechanism through other physicians going in and doing those house calls. It will become a bit tricky from a billing perspective. We're well aware of the billing pitfalls we may run into and intricacies with outside use, and do we use sessional fees? So we're well aware of those issues, and we're trying to find a solution that works best. Again, the simplest, cleanest solution is for people to vaccinate their own patients. What will likely happen, and we're working on this, is that the health unit will have an accountability agreement with some kind of primary care entity, and once each physician has identified those patients, then we'll figure out how exactly we're going to get those doses into those physicians' hands. It will be a very, very controlled process. It's not going to be that you're going to be given, 20 doses and put these in your fridge and do them when you can. It will be a very timed process. There may be probably be COVAX training associated with this. So again, it's going to be a very, very specific process. But again, more details will be coming out in the next, hopefully, few weeks about that once we nail things down. Happy to answer some questions later on. The things that we need to keep in mind in terms of immunizing in homes is that there will be that 15-minute monitoring period afterwards. So it's perhaps not as easy as other vaccines that we've given in homes where they've had flu shots for 20 years. We pop in, we give it, we leave. It's not that simple with the COVID vaccine, obviously. So there is that monitoring period. There will be the COVAX, entering, and it's not a hugely complex process, but having taken the full end-to-end training myself, it's not as easy as just logging into a system, quickly entering something, and that being it. So there is a bit of complexity to COVAX that people need to be aware of. So that's what's kind of that's what's in planning right now. I know we want this to happen today or 2 weeks ago. Obviously, all of us sense the urgency to this, but we're having good conversations with the health unit. Dr. Summers has been receptive to what we've been throwing him so far, and hopefully we have some answers for you soon.
Great. All right, and then I wanted to talk about another important strategy for primary care that we would like to work on with you tonight. And that's planning outreach to marginalized communities in London-Middlesex. And these are people who will need some extra support in, first of all, choosing to be vaccinated, dealing with a vaccine hesitancy, extra support in getting to mass vaccination clinics, so we can try and troubleshoot some ideas about that. But then also there will be some groups who in some cases would benefit from a pop-up clinic going into their neighborhood. And we're thinking of groups of people who have really significant barriers. Of course, first of all, we encourage everyone to go to mass clinics, but for those with significant barriers, we want to work on some solutions. So we're thinking of people who can't manage the technology that would be involved for booking or have no one in their life who can do that for them. People who have language barriers, hesitant to go out in public because of those language barriers. There are big transportation issues for some people who have, if they would have to take 2 or 3 buses and they're older and they're afraid of being out during COVID, that's a real disincentive. And there also are groups of people who have trust issues and have problems because of traumas that they've experienced. So just being in the big system, putting their names down in this big system might be hard for them. So a group of us at LMPCA are getting together, talking about this, talking about it with Dr. Summers and Dr. Mackey. We've also been liaising, we have liaised with the Intercommunity Health Center and Cross-Cultural Learner Center. So those are organizations that have a lot of experience working with and reaching these people. So we're learning a lot from them. But in addition, we'd like to hear your thoughts and hear from you, because you are the people in these practices who know these people and have knowledge of where these groups of people might be, the marginalized, vulnerable populations. So we'd really like to hear from you if you have ideas of how we can reach them, of possibly where their neighborhoods are, where a mobile team going into their community would be useful. So we can talk about that in our breakout rooms. We can also certainly invite you to come and give us feedback and ideas through either at some of the meetings that we're having, or just reach out to the LMPCA email address and we'll get in touch with you. But anyway, first of all, we'll talk about it in the breakout rooms, and that will be great to get some of your ideas. The other important aspect that we'd like to consider for this outreach is identifying groups of seniors who live in community clusters, and this is beyond the organized retirement communities. And these groups of seniors might also have hesitancy in going out because of transportation issues or just being afraid of being out in the community during COVID. So we're wondering about we're working on identifying them and setting up mobile teams manned or womaned by primary care to travel to those, and we call them the naturally occurring retirement communities. So we're working on that goal and trying to work with some experts about identifying where those communities might be. So again, if you have ideas about that, if you know, seniors apartment where you have dozens of patients, then let us know about that as well in the breakout conversations. So that's all for me. Thank you.
All right, thank you both Mario and Julie for those insights. We're going to be talking a little bit more about what Mario and Julie spoke about in the breakout groups shortly. There's just a question in the chat section, Alex, that I'm going to ask you to comment on. Sarah Puente asked if, because AstraZeneca is now approved for over 65, can you book in the pharmacies for that? My understanding is that it's still between 60 and 64 only, or is that incorrect?
That has evolved since Friday. So eligibility in those pharmacies, to my understanding, is now open to anybody over the age of 60, not just the 60 to 64 population. You may also be aware that there are some people from our region that may have gone to other regions where those pharmacies exist to get the vaccine. They are not screening by postal code. So certainly that is permitted. So yeah, that's evolved since Friday, certainly.
Okay, thanks, Alex. We'll answer a lot of the other questions that people have posed right after the breakout groups. So we're going to now ask Janet to put us into breakout groups, and the basic questions that we're going to be entertaining within the breakout groups are any questions that you might have for Alex or the Middlesex-London Health Unit in general, and then questions regarding Julie and Mario's presentation, and anything else that we want to discuss as time permits. So once we get to the end of the breakout groups, we'll be plucked back into the bigger group. So please stay online and come back for the question and answer period with Alex.
Everyone's just heading back into the main group here. And Alex, I've been gathering lots of great questions from all the different breakout group discussions as well. And we'll try our best to get to as many as we can, but happy to share and make sure that they get answered by the most appropriate colleague as well. Phil, I don't know if Phil and Julie, you're back on here as well.
Yep, we're back.
Yep, we're all back.
Okay, awesome. Sorry, I just wanted to give everyone a minute to reorient back to the larger group here. Here's a question right here, Alex. Will we be able to vaccinate essential caregivers in the home with the housebound client?
Yeah, that'll be fine. I think generally speaking, when we talk about these home visit protocols, it'll be focused to getting to that specific population. But if somebody is eligible in any other way and you're out there and they're in the home, that makes good sense.
Alex, maybe just on top of that, and just popping in here, there's some discussion in phase 2 about eligible caregivers of people being in part of phase 2, which is slightly different than your answer. So I'm just wondering how that fits into this.
Sorry, Gord, hit me one more time with that.
Just that there's something in phase 2 about essential caregivers of people who have health issues being identified in phase 2 somewhere along the way. I forget where it is in the priority of highest or very highest or important or whatever the terminology is, but that's sort of something new into that phase 2 and just how that fits in versus the question that Kathy put in the chat about the essential caregiver.
Yeah, so the definition of an essential caregiver is going to be an important distinction in who's eligible and who's not. So to date, essential caregivers have been defined as those that are registered with a long-term care home or retirement home. Moving forward, essential caregivers will obviously include that group. They'll include other essential caregivers in other congregate environments, and then people who have either highest priority health conditions or highest risk, or high risk health conditions may have one caregiver vaccinated and included. And to be an essential caregiver, it's this idea that you're somebody that's providing daily assistance with activities of daily living, that type of thing. So for those homebound ones, it's a bit nuanced, right? So technically being homebound in and of itself isn't, I would say that essential caregivers of homebound patients aren't necessarily eligible unless that homebound person is eligible for a reason that is a highest risk priority. Now, That is too complicated. I don't really want us collectively to get stuck on those types of nuances when we actually do the rollout. So we will make sure we've got that specificity when we provide guidance to you as you take those vaccines out and as they get sent to your office. Because again, the more complicated we make the eligibility criteria, the slower we will go. So it is a bit of a dance that way.
Alex, the question came up in our group around transportation to and from vaccinate. So if someone who isn't strictly homebound but has difficulty getting transportation wise to a vaccination center, obviously paratransit would be an option. Are there any other mechanisms that have been put in place that you know of, or is
at the moment it would be paratransit?
Yeah.
We have not to date facilitate, like, again, paratransit would probably be our best option regardless. At this point in time, there's some discussions about moving to buses to help pick people up in certain communities and all that stuff, and we will get there. And Julie, we've spoken about that. I think there's definitely some options there. How do we do so safely, and when do we get there? But yeah, no other specifics on that platform at this point, Mario, other than the paratransit option.
If Manassi does change their 4-month interval, obviously those 80-year-olds are going to be contacted through the means that they've provided, whether it be email or phone. Pretty confident that will kind of capture them all and notify. Like, will we be expected to play a role in that in terms of communicating them? Will that be entirely through you guys and COVAX?
Through us.
Yeah.
So if there is changes to the second dose interval, that'll be on our clinic staff to figure out how to get them back in. We, through our booking system, there's a large degree of automation that we can utilize, but there are those for whom that won't work, and so that'll be a phone call.
Alex, there's a lot of questions about COVAX as well, and I see Jessica Hunter-Orange has posted a question that encapsulates a few groups' questions. So when I popped in, can you please outline anything you know about COVAX Ontario data being able to be dumped into family physicians' EMRs?
Yeah, great question. I do not know that much on that yet. We haven't heard any of those details through the information we've received from the province. I must admit, I'm still having some problems getting information out of COVAX at a health unit level, so we're still working on that aspect of it. But no, I don't have any other details on that, Jessica. I'm sorry.
There's another question here, question for Alex from Family Doc. Getting in ahead of the game when looking at the eligible household group, is there a specific definition or can be at the discretion of the or a family doctor? For some, anxiety, dementia, or other issues may prevent them from being able to attend mass vax clinics.
Alex, you're muted.
Oh, you're on mute, Alex.
Sorry, thank you. In terms of the definition of essential caregiver, there is one outlined in the phase 2 prioritization document that was developed by the province. And it's really about folks that are providing regular, like daily support and activities of daily living. So those are the essential caregivers that are being defined here. Now, I certainly think that there will be flexibility around, how people define that. But that's really the definition there. The second part of this question, Janet, for some anxiety, dementia, or other issues that may prevent them from being able to pay a mass vax clinic. So certainly I would, if there's concerns about people having support, bring them to the mass vaccination clinic. That's no problem. Somebody can help you come to the vaccination clinic. That's no problem. We facilitate that already and all the time. So that's no concern on that front. They just may not necessarily be eligible to get the vaccine when they come in.
I think I can maybe provide a little more clarity, Janet. So really, if the patient's otherwise eligible and the family doctor is aware that they can't get there, in terms of these lists that we'll be producing, they could be on the list, but again, it's the discretion of the family doctor whether they, do they want to be doing the house call on that patient who would otherwise be eligible, who they don't feel that they can negotiate to get them to the mass vax clinic. So it comes down to their underlying eligibility first and foremost.
Yeah.
Less so than their ability to get out, because again, it's going to be how much work is the family doctor going to want to do all these house calls for people who they think maybe they could nudge to the vaccination clinic.
Right. So then there's the follow-up to that, further to that question for Alex. What if we just had 12 patients that were eligible, but we don't, but we know won't go to the mass vax clinic? Can we just get doses for them and do in combination of house call and in office on the same day? So I guess a little bit more to that, but it sounds like from what you and Mario were saying consistently with if they are within the appropriate age groups that we're currently vaccinating.
They have to be eligible for sure. And I think to the question of, if we give you a vial of Moderna and you're using it appropriately, are you able to use a majority of it in your clinic and then go do a couple of house calls? I think in the long term, once we get really into broad distribution, that's absolutely going to be the situation for you, a similar pattern to how you do use influenza vaccine potentially. At the moment, again, these are fairly tailored pilot programs we're looking at as we get more into that broad distribution a little bit later on.
So then another question I see coming in via email or text, was can we find out if Alex thinks COVID vaccines will become annual?
I don't know. I don't know yet. Yeah, I don't know. I think that we will have some clarity on come the fall as we get a better understanding of how much the vaccines drift and variants change the amount of immune responsiveness of somebody who's been immunized, and then also the effectiveness and duration of the vaccine immunity. So I don't know the answer. I don't think that a COVID vaccine is going to last you for life. I can tell you that much. Whether it's annual or who knows how often, don't think it's going to last you for life.
Another question related to tech that I see coming in is what technical supports, for example, documentation, would physicians receive when they're asked to participate in the rollout of the vaccine in their offices?
So documentation, so certainly there would be likely, and again, some of these details, I don't want to get too far into the details until we have them firmed out, but when you are participating in this distribution, we will likely have to have some degree of an agreement with any physician that is taking vaccine and distributing it or using it. And that's kind of the premise that we're building some of these home visiting pilots around, as Mario was articulating. So that type of documentation would be in place, the COVID's training, et cetera. Beyond that, I don't know exactly what kind of documentation we're talking about, but that would be the key, is that agreement.
Yeah, and similarly, I think, Julie, I don't know if you want to expand on the question that you typed there. Is Ontario MD COVAX training necessary if a doctor has already worked at a vaccination clinic? Is there more training needed to vaccinate in our offices?
Yeah, probably very little training. What we're trying to look at on our end is how do we make the, this is real inside baseball, how do we make the vaccination event specific to you as a provider without making you the administrator. MLHU remains the administrator. We create an event for you and you deliver as a vaccinator within that event. Long story short, we're trying to make this as simple as possible so that if you've done the COVAX training to be a vaccinator, this is actually fairly simple, would be the objective we're trying to kind of replicate here.
So maybe I'll pause. Oh, sorry, go ahead.
I was just going to ask Kathy's question, which was a good question that Kathy typed. If someone got their first dose, travels to Toronto or Windsor to get their first dose, can they get their second dose in London 4 months later? Like what will happen there?
Yeah. At this point in time, the expectation, generally speaking, is that you should plan to get the dose, your second dose, in the clinic in which you received your first dose. However, we've got some clarity from the province because we know that there'll be people, for example, all the residents who are graduating this year may have received their first dose here and then might be off in Ottawa or who knows where by the time July rolls around. And the province will certainly by that point be able to provide vaccinations to other clinics. Now, the details around how you book an appointment, I think that will come through the provincial direction as we get closer to those June, July, August appointments. So I do anticipate you'll probably, if you got an AstraZeneca in Windsor, probably be able to get your second dose here in London. And one of the bonuses of having everybody on this COVAX system is that we will be able to know that you got your first dose through checking the same system. So theoretically, this, and I think operationally, this will be feasible.
Great. So just in the interest of time, I know we have 5 minutes left, and there are many of us still on the line. There are still questions I see coming in. I wanted to give a chance for anyone who wanted to unmute and ask a question to the group as well, or to Alex.
Janet, it's Gord. I actually had one that came up in our group that I thought I'd just bring out to Alex here. And you mentioned that in the highest risk groups in phase 2, you mentioned the kidney patients, and the GFR less than 30 was what was put up on the list. So one of the things that came to mind was a number of our patients with GFR less than 30 are actually not seeing nephrology yet. We're still managing in our office because they're hovering and we haven't referred, but technically they fall within the criteria. And so if you only go to the nephrology clinics at LHSC, those are ones that are going to be missed. So when we look at the ability or the need for primary care to identify them, is that a group that we will need to identify? And if so, that's something we're going to have to move on quicker to get that identification process, because that is one that's the highest risk group in phase 2.
So Gord, I can jump in here too. So I think with the GFR group, I've done some searches on our own patients. The age cohorts will capture most of those GFRs less than 30 in those who aren't seeing nephrology for the most part. There's going to be one-offs, and I think we need a mechanism that we can email the health unit if those one-offs come about. But I think I've looked at my own data, and with the exception of I think 2 patients who are in their 70s, all the other GFRs under 30 who aren't being seen by nephrology are 80 and above. So they probably would have been captured by. Now, I think one though that we're going to have to talk about is that MS group, because there are a lot of MS patients who we're following who aren't seeing neurology, especially with the turnover with some of the MS doctors here in town, and they haven't been followed by specialty clinics for many years. So that'll be one group that, in the next few weeks when that group does come about, Alex and I we'll want to have some conversations about how family docs are going to notify these patients, how we're going to identify them, and to make sure they're not missed, because especially clinics alone aren't going to capture a lot of them.
That's really helpful. So there's some gaps there.
Yeah.
I would say if Mario, if your evidence holds up across most primary care, we're going to be at age 70 by 3 weeks. So let's just say that's going to come out in the wash, but those MS patients for sure, that's a gap.
I would be interested what those hospital groups tell you in terms of, so the transplant patients, are they confident that all of their post-transplant patients are being followed in those clinics?
Yeah.
I think for the most part, that's probably a safe assumption, but just getting their take on that.
Yeah.
I think the patients who've had leukemia or lymphoma in the last year, again, they're going to be well aware of who those patients are, and they may not need again, there are going to be some gaps, right? If someone's moved here from Toronto and doesn't need any longer term follow-up, and now we're their primary, there's going to be some gaps, and I think we need a mechanism to feed that back to you guys if there's some small gaps. The MS is the big group that I kind of see from that. Welcome any other feedback from any of their family docs if what they think about that too.
See, there's many more questions that are still coming in. So what we'll do is collect all these questions as well, the questions that you spoke about or discussed in your groups as well, and we'll try to kind of create a mini little perhaps FAQ or something towards the end as well before our next session. And maybe I'll hand it back over to Phil for some next steps and conclusions.
All right. I want to thank everybody first of all for joining us tonight, and I want to thank Alex in particular for coming to us and as always help us with getting all of this in our heads properly. I think what we've learned tonight that there is certainly a large role for primary care to play. And that role is coming out now, today, and in the next weeks ahead of us. Part of it is going to be identifying people who the health unit wants us to identify. When we get to the process of doing that and the health unit asks, there are some billing codes that we can potentially use to help to mitigate some of the costs that may occur in doing this. So certainly we have some help in that regard, and it's something to think about doing, and we encourage everybody to partake, whether it is paid for or not. We are right now really looking at those people who are 75 plus, who are homebound and eligible recipients. And we want you to think about how you can find the people in your practice, if at all possible. Mass vaccination clinics are, of course, the way to go for getting the most distribution, and that's still with the public health unit. And we are encouraging actually in primary care, because I don't think we can do the numbers in our offices, quite frankly. We're going to be having a role in finding the high-risk health conditions and the at-risk health conditions when that becomes the dominant part of the campaign or the phase that we're in. So lots of places for family physicians and nurse practitioners to help us to identify these people. And I think we can be creative over the next little while to try to help everybody to get these COVID vaccines into the arms of people, which is where they'll be helpful to get us all back to a community where we can kind of live life like we used to live life. So I'd like to thank you again, and I'd like to thank our speakers, Gord and Mario and Julie and Alex and Janet for their help, and behind the scenes, Drina and Jessica and Dan and Benit, and I've forgotten somebody, I apologize. Anyway, thanks everybody. Have a wonderful night. And Janet, did you have a poll that